Thank you all for joining us today. For today's program, we're grateful to sponsor Mental Health Matters, interview with the Geriatric Psychiatrist, hosted by the Massachusetts Association of Mental Health. Dr. Stephen Pinals will be answering commonly asked questions that many adults have as they get older, and the discussion will include the importance of geriatric psychiatry. Dr. Stephen Pinals is Chief of Geriatric Psychiatry at Cambridge Health Alliance and is board certified in psychiatry and neurology with subspecialty certification in both geriatric psychiatry and psychosomatic medicine. We have an expert with us this morning, and it is with great pleasure that I introduce Dr. Pinals. Over to you.
Thank you, Deb. I appreciate that very kind introduction, and thank you, Cassie, for inviting me to participate today. It's my pleasure always to speak about mental health issues. And I'm going to start with an overview of what geriatric psychiatry is. And then with Cassie's inspiration, she supplied me with a few questions that she thought might be relevant for me to address today. I'm going to make a few general comments about the experience of aging. We'll talk a little bit about loneliness, anxiety, depression, and then some lifestyle changes we might want to consider as we're growing older and trying to live in this very fragile world, as you were noting, Deb. It is a delicate time. All right, let's start. This is, well, that's interesting. There we go. A slide we all know well, right? The exploding growth of our older adult population, particularly now that the baby boomers have turned 65, there's been an exponential growth in older adults especially, which has put tremendous pressure on our healthcare system. And just to give you a relative kind of chart, we've got a lot of pediatricians. We certainly know the more the better. OBGYN also in short supply, cardiology, but look at that geriatric medicine and family internal medicine circle. 7,040, this data is only 4 years old. If we were to put a little circle there for geriatric psychiatrists, it'd be a tiny little circle. There are about 1,500 board certified geriatric psychiatrists across the country. Nowhere near the number that we need to address the exploding growth of older adults with mental health issues. So a lot of our work becomes educational and supportive to our colleagues in medicine. And so over these, we know that older adults tend to get their psychiatric care from their primary care doctor. Most older adults don't show up to see a specialist until they're referred. They'll start with their PCP. And over these last 20 years, there's been a real explosion of growth in the collaborative care models, which is really an integrative care model where we don't have a psychiatrist sitting in an office waiting for patients to show up, but rather we have mental health specialists, usually social workers, who are embedded in the primary care office, and they serve as consultants to the primary care team. So this has helped mainstream and it helped improve access for folks that may have depressive or anxiety symptoms or trouble sleeping, and they don't need to see a psychiatrist, but they need some advice. And those behavioral health specialists have access to a clinical nurse specialist with advanced training in geriatrics or to a psychiatrist who can help guide them in making recommendations. For patients that have more complex psychiatric conditions like bipolar disorder or severe depression with suicidal thoughts, that kind of thing, there'll be a referral to a specialist. And oftentimes that first visit looks like this. You'll have someone taking your history, interviewing the family, the caregivers, doing some screening. And what distinguishes the geriatric specialist is probably more attention to these other caregivers and other sources of information in the cognitive screening that we hopefully do with every single encounter, looking at functional capacity. How well are our patients managing their own care at home? And that can range from shopping, cooking, dressing, managing the bills, driving to appointments, to some even simple matters of feeding oneself. How much care is required for that adult to be safely cared for at home? Naturally, we all check the physical exam, neurologic exam, and lab tests, brain imaging if that's indicated. But really, the the focus of the geriatric provider is in the coordination of care. Far too often, older adults have many different doctors who are making many different decisions and adding to that growing medication list and maybe not pulling it all together. I like to think that geriatricians try and step back and take the big picture. And the part of this work that I enjoy the most, of course, is the family work. I love this part of my job where I get to interview the spouse, the children, the caregivers, and get hopefully a full picture of what's going on at home. And much like child psychiatry, geriatric psychiatry involves a lot of family work. So for those patients who don't have a full family investment or a group of caregivers, we're looking at a different set of problems. But before I get to that, I just want my summary slide. Geriatric psychiatrists focus on prevention, evaluation, diagnosis, and treatment of mental and emotional conditions. In our specialty training, which occurs for an additional year after our adult psychiatry training, gives us some experience working with older adults who have complex medical conditions and are dealing with other challenges of aging. And we're certainly all aware of what those challenges are, things like retirement, loss of income, the change of identity that comes with those changes in your productivity, loss of independence, greater reliance upon family and friends, the disability that eventually will come with any number of medical conditions, and of course, sensory loss, hearing loss, visual loss. And the big one is social isolation. And I know that AARP has done a lot of work in researching and promoting awareness of the impact of social isolation and loneliness. Over these last 20 years, there's been a tremendous amount of research looking at this issue in particular. And we now have really good data that suggests loneliness increases the risk of all of these medical conditions, increases blood pressure, increases the risk of heart attack, stroke. It worsens diabetes. People with severe loneliness will have a reactivity to infections. Their immunological response is changed by the stress of being alone. And of course, there are changes in cognition and increased risk for dementia, which I'll show you a study in a moment. But in psychiatry, what we see is a real clear correlation between loneliness and anxiety and depression. And I'm going to spend quite a few minutes talking about depression, but I really only wanted to mention anxiety is a whole talk unto itself. That requires another 45 minutes of discussion. It's such a huge subject. It is the most common condition of aging and one that many people suffer from alone. It rarely comes to our attention until there are some other problems with health that bring it to our attention. And anxiety, like depression, is a treatable condition. We're talking about not just people who have anxiety from early age, young adult onset, but rather late onset anxiety that typically occurs along with new medical conditions or progression of medical conditions in the experience of feeling alone or fearful for your survival and the uncertainty of knowing what's coming next. Anxiety is unfortunately one of the most devastating diseases of psychiatry, aside from depression, which I want to talk about next. So before I do, this study just done 2 years ago showed that loneliness was associated with a 40% increased risk of dementia over 10 years. That's just a phenomenal statistic. So controlling for gender, race, ethnicity, education, genetics, et cetera. Just a big jump in people who suffer from cognitive decline. And we saw this most apparently during the age of COVID, when older adults especially were terribly isolated and unable to be in touch with family or their usual supports. And the effects were, I think, not well known until now that some of the COVID restrictions are being lifted. We have a sense for the true impact of this new condition. So I want to spend a few minutes talking about grief and loss. Grief, of course, is the emotional response to loss. There are many emotional reactions that may occur in the acute stage: shock, disbelief, anger, sadness, despair, along with physical reactions, including difficulty with sleep, anxiety, loss of appetite, poor concentration, attention, the sense of time distortion. And there are many different types of grief. Acute grief being that which we just mentioned, occurring right after the loss and occurring for many months. Often those feelings of acute grief will diminish over time. We hope that over 6 to 12 months, there is some integration that occurs where you're able to look at that loss and understand that life must go on for the living, and the feelings that have been overwhelming and have caused impairment in function hopefully will gradually diminish with the right kinds of support. But when they don't, we start talking about complicated grief or prolonged grief disorder, which is really a failure to adapt to that loss. So complicated grief refers to a condition where there is intense sorrow, pain, and rumination with focus that never lifts on the, after a loss, we're often faced with reminders of the loved one. And either there's an extreme focus upon those reminders or an avoidance. In either way, it becomes a preoccupation that gets in the way of growth. So that persistent longing for your loved one, difficulty accepting the death, numbness and detachment, sense of bitterness, loss of trust. And then as this worsens, the feeling that life holds no meaning or purpose. And there's just an inability to enjoy any aspect of life or recall those positive memories from the past. Not surprisingly, complicated grief is twice as common in older adults than for younger bereaved adults. And nearly 1 in 10 bereaved adults will progress to this complicated grief condition. And not surprisingly, women are at greater risk, being more emotionally connected. Generally speaking, women tend to be at greater risk for depression, anxiety, and for the complicated grief conditions. When complicated grief persists, we hear that our patients are having trouble managing at home, managing their own self-care. They tend to isolate from others and withdraw. And there's this process of ruminating. If only I had done this differently, perhaps I could have prevented the death. And of course, the feeling that life isn't worth living, severe depression, guilt, self-blame, and wishing that they had died along with their loved one. These are fairly common findings with complicated grief, and ones that will hopefully bring that person to our attention. There are many different types of therapy and counseling that have been used in grief work. We haven't time to summarize all of them, but they all really build upon these building blocks. That psychoeducation, what is normal and what can we expect with normal, healthy grieving? Sometimes it's a relief to hear that what somebody experiences is not pathological, it's just part of the grief process. So we encourage the mourners to talk about their loss and express their emotions. Looking for different coping strategies and recommending more productive pathways is always the focus of the work, and helping that bereaved person shift their focus away from the deceased individual to their own life and their own survival. So there are cognitive behavioral type strategies to help address prolonged grief. There are more psychodynamic or supportive type psychotherapeutic processes. And of course, many adults who are suffering from prolonged grief will end up on medications to help with their difficulty sleeping, their loss of appetite, or symptoms of depression that might emerge. All right, let's talk about depression in the older adult population. Depression is a leading cause of disability all over the world. And if we look at not depression in the formal sense, but depressive symptoms, we find them in up to a quarter of older adults. The highest rates occurring, as I already mentioned, in older women. The oldest old, that is people over the age of 80 and up, and those with medical disability, medical conditions, and cognitive impairment are at highest risk. Depression in late life is often under-recognized and under-treated as a result. And that's really the most important part of our work, is identifying those folks that might benefit from treatment and making sure that the primary care physicians that we work with are able to screen adequately and have a pathway towards getting help. Surprisingly, there is no increase in major depression with aging. A lot of the young doctors that I train have this assumption, which I believe is a cultural one. If you get older, well, of course you're going to get depressed. Who wants to get old? That's depressing. But in fact, the prevalence of major depression decreases in that last generation. And it's probably because older adults with a lifetime of experience in managing grief, loss, despair, and different challenges may have a little bit more resilience than a young person who has their first episode of major depression. We see, in fact, depression that is related to or a consequence of a new physical health condition. And so for that reason, these two problems, mental and physical health, are inseparable. So we have to look at the whole patient. A lot of the common medical conditions that older adults suffer with are correlated highly with depression. So stroke being among the top contenders here, it depends where your stroke occurs, but you can see a 40 or 50% increased risk of depression after a stroke. And that's not necessarily correlated with the physical disability that occurs with the stroke. In fact, it's probably a central effect. It's related to the changes in brain chemistry that the depression is at higher risk in these individuals. So there was actually a study done 17 years ago where patients who suffered a stroke were automatically given an antidepressant, whether they had depression or not. And that antidepressant had a protective effect and reduced the risk of depression in that cohort. Of course, there are risks of antidepressant medication, so that's not a standard practice, but it just shows how deeply prevalent this problem is. With cancer, heart disease, Parkinson's, diabetes, and many, many other medical conditions, we see a big risk of depression. And the most common medical condition of all, arthritis, a 13% risk of depression. And so that, again, half of older adults have arthritis. And so that just represents a huge subset of our older adult population. Late life depression is often more difficult to diagnose. Older adults tend to have a somatic presentation. That is, they're more focused on the physical symptoms. You might hear about an older patient who is just ruminating about their bowels or about chronic pain conditions, any number of somatic presentations where the focus is on the body and not the mind or the emotions. Older adults tend to have more cognitive impairment, no surprise, and executive dysfunction. That is, problems with organizing, sequencing, planning. And often that's related to small vessel disease, little tiny strokes in the brain, which can be detected on MRI or other types of brain imaging studies. Another reason late life depression is so hard to diagnose is that a lot of these somatic symptoms of depression, here are all the symptoms of depression categorized, both psychological and physical or somatic. And so a lot of these somatic symptoms, like change in appetite, loss of energy, changes in sleep, restlessness, those are symptoms that may go along with any number of medical conditions. Or, of course, we see changes in sleep just with natural aging. And so a lot of these somatic symptoms are not necessarily specific. So we look more towards the psychological symptoms: depressed mood, loss of interest, pleasure, feelings of worthlessness or guilt, problems with concentration, attention, and of course, suicidal thoughts. That is our biggest fear. The older adult population being, of course, at the highest risk for suicide, white males making up the largest portion of that group. We see that giant, that steep rise in suicides at the end of life. Those are generally white males who are suffering from depression. They're alone. They might have access to a firearm. They might have trouble with substances like alcohol. They tend to have one or more medical conditions that are poorly managed. There's a whole set of risk criteria that we look at to determine if our patient is at risk for ending their life. And so without question, without exception, every single older adult that comes to our attention, we ask, have you had thoughts about not wanting to live anymore? Has it ever reached the point where you've thought about taking your own life? We ask these questions because it may be a way to prevent the act from occurring and help people get into the right kind of treatment. Depression is a risk factor for dementia, particularly Alzheimer's disease. In fact, a lot of patients with new onset depression in late life, it's a prodrome. And so as part of our workup, we always check cognition. And that could be the form of a quick memory test. The mini cog, we tend to use the MoCA here at Cambridge Health Alliance, the Montreal Cognitive Assessment. And really, we're trying to get a sense for any change in cognition. And depression with cognitive changes increases the risk of dementia more than twofold. And so these patients have to be followed closely. One of the most common presenting symptoms of Alzheimer's disease is apathy. And that apathy, where people are just shut down and not engaging, not talking, not participating, not joining in, it looks like depression. And those adults in particular are brought to my attention by their loved ones with the question, what's going on? There's something changed, something's not right. My parent or my spouse, they must be depressed. And so we do the workup, we do the evaluation. And in fact, yes, there may be depression, but it's also the beginning stages of Alzheimer's disease that we need to address more closely. Okay, so a big headache. I'm just talking about all the miserable parts of aging. So let's talk about treatment just for a minute. And I'm not going to spend a lot of time on this. If there are particular questions, I'm happy to answer them. But suffice it to say, we know that psychotherapy and antidepressant medications are effective almost 2/3 of the time, sometimes more, depends on the cause of the depression. Psychotherapy, of course, is challenging because it's hard to find therapists in this day and age. The access problem has been really challenging for us here and all across the country. There are waiting lists for therapists. But I always strongly encourage my patients to get on that waiting list because it's the only chance to get the right connection to somebody you can talk to. And it could be a piece of work that is 6 to 12 sessions to really address some specific problems, or it could be long-term psychotherapy, or it could be a cognitive behavioral approach to really look at some of those thoughts that keep going around and around and lead to this cascade of symptoms and findings that are hard to dig out from alone. Dealing with a loss, dealing with a life change on your own is really hard to do. And people say, I don't need a therapist, I've got friends. And a friend is not the same. A trained and skilled therapist is really essential in managing the tangled weeds of depression in late life. For medications, we've got a long list of options, including the SSRIs, which are the ones most commonly used. These medications are not without risks and side effects. They're commonly prescribed by the primary care physician. So when a patient comes to me, finally, they've often had trials on 2, 3, or more different antidepressants. So then we get into more novel or sometimes older medications that aren't utilized quite so often, or combinations of medications, which in some instances can be effective. For more severe depression, that is in particular psychotic depression, where patients may have paranoia, hallucinations, or other types of psychotic symptoms, ECT is the treatment of choice. Nothing works better. Unfortunately, there's quite a stigma attached, and I don't think Hollywood has helped that any, but the new ECT that is now provided significantly reduces the risk for any memory loss or cognitive problems that we saw in the old days. And there has been a lot of work now looking at transcranial stimulation, which is basically a large magnet which is placed close to the scalp. It's been shown to change neuronal structure and chemistry in a way that helps relieve depression, sometimes anxiety, and other psychiatric conditions. Medicare and private insurance carriers will cover this treatment. It's highly effective without all of the risks of anesthesia that come along with ECT. Light therapy is one of my favorites. It was initially developed for the treatment of seasonal affective disorder, SAD, and it's used in a very effective way through the winter months. But it also works for other conditions. So it's an underutilized treatment. The light box costs a pretty penny, but you can buy one actually used on sale at Amazon or one of those carriers. And it's a good investment for those who tend to get depressed every wintertime with the loss of light. And then the subject of alternative medicine, really quite a long and detailed conversation, but there are some substances that are available in natural health food stores or in your grocery store that have been shown to help depression to some degree. And in particular, St. John's wort, you've heard of that, works by the same mechanism of those SSRI antidepressants. SAMe, another natural remedy for depression, has some small effect. And there are other herbs and alternative medicine treatments which are highly effective for some, but not for all. And unfortunately, we don't have a lot of good evidence that they work consistently across large groups of individuals. So what I prefer is to focus on prevention. And what can we do in terms of changing our lifestyle to help reduce the risk of depression as we age? And so exercise and activity is the top of the list always, and I'll mention that again in a moment. Sleep hygiene is a huge factor. As I mentioned earlier, our sleep architecture falls apart with aging. We tend to spend more time in bed and less time sleeping. It often takes longer to fall asleep, and there are more numerous nighttime awakenings. Our deep, slow wave sleep, that deep restorative sleep, tends to diminish over time, and we wake up feeling more tired. And so what do? We go to the doctor, we get a sleeping medicine, and that actually makes things worse. So a lot of the sleeping medications that are prescribed, particularly the benzodiazepines like Ativan, Klonopin, Restoril, Valium, Librium, there's a whole long list of these benzodiazepines. These medicines will actually improve the light stages of sleep. They help you fall asleep, but they will in fact block or diminish the ability to have deep, slow wave sleep. So again, they're not good for that deep, restful, restorative sleep. They help you fall asleep, and then you wake up the next morning and you're more tired than when you started. These medications have also been shown to impair memory, increase risk for falls, and hip fractures as a result of that. So I really try to stay away from the sleep medicines. What we use instead are low doses of the antidepressants that are more sedating, which are not habit forming. But really the best treatment for sleep is exercise and activity, making sure you avoid caffeinated products before bedtime, making sure that you go through your routine and slow your breathing and slow your thoughts and do something more soothing like reading or meditating or listening to music. It's kind of a ritual that we've lost over the years, but attending to our sleep is crucial to our mental health. It's often the first thing to go in depression. People with new depressive symptoms will report waking up early in the morning and having difficulty falling asleep at night. And that dysregulation of sleep causes impairment in cognition and mood, et cetera. So it's a real, it's a circular kind of process. Paying attention to our diet is crucial. Optimizing our medical treatment, keeping our blood pressure under control and our diabetes regulated. Avoid smoking at all costs. Alcohol is often used by older adults to help initiate sleep. And it's the same problem as benzodiazepines. It may help you fall asleep, but then after that alcohol wears off a couple hours later, there are micro awakenings all night long. So alcohol actually disrupts sleep and causes a worse quality of sleep. And then, of course, the most important first line of defense is social interaction. And that involves hanging with people you trust, finding your posse and reaching out and connecting with people. There is no better way to help ward off depression and all of the risks of depression. Choose the right foods. Boy, that hamburger looks good to me right now. But now we got to stick with the rabbit food on the right. And we know from years and years of research looking at the Mediterranean diet, and this newer adaptation of Mediterranean diet called DASH, this dietary approach to stop hypertension, which again is building upon fruits and vegetables, whole grains, lean proteins, has been shown over and over to reduce blood pressure, hypercholesterolemia, and increases well-being in older adults especially. And then exercise. We can't say enough about how important exercise and physical activity are to our well-being. It has been shown to lower the risk of dementia. We know it can help depressive symptoms and reduce the risk for anxiety. If you're having an acute anxiety attack, there's nothing better than going outside and getting fresh air and changing set and having a different kind of stimulus to your brain. And even moderate exercise, such as walking a few times a week, has been shown to significantly lower risk. All right, in summary, grief is a normal part of aging. Depression is not. Lifestyle changes will lead to healthier and more gratifying aging. And geriatric specialists hopefully will help provide some expertise in caring for older adults. Thank you. I'll stop sharing now.
Thanks, Dr. Pinals. There's a couple of questions in the chat. One
Sure.
is, how can someone help a person who is experiencing their first major holiday without a loved one?
That's a good one. Yeah, so this is the most difficult time of year when we expect to be with family or we planned to be with family who are no longer with us. The best possible way is to use your intuition, and it's called being present, bearing witness. So when somebody has lost a loved one, there are really no words. There are no words to convey the empathy or sadness of that loss adequately. So what we do is we join with, we sit with, and we bear the pain of that loss with someone. By sharing it, it gives the grieving person a sense of, I'm not alone with this. And so that is the most challenging prospect of how to manage grieving, sitting with that unbearable, uncomfortable loss. And then, of course, naturally, bringing food, right? There's something good about having somebody bring food. When you know someone who suffered a loss, bring them food, because who feels like cooking when you've lost a loved one? Make sure that you're available to them. Leave your phone number and say, if you're having a tough time, you reach out and call me, because we know grief comes in waves of despair and sadness. How could this have happened? And you just need somebody to reach out to during those precious moments, those difficult moments. And then knowing when that grief is progressing into a more destructive condition, like we were talking about this complicated grief disorder, and knowing when to help that person reach out to get an assessment, perhaps with their primary care doctor or with a specialist.
Thanks. A related question, can complicated grief occur with something other than the death of a loved one? For example, a bad breakup?
Bad breakup, the loss of a pet, the loss of any loss. Grief can occur with the loss of a job, right? Grief can occur with even losses you hear about. They may not even be your loss, but it might trigger the memory of a loss that you've had in the past. So there is the general category of loss. It could be anything. And we often don't even know why we feel so sad when we do in a particular day. And it requires some reflection. Oh my God, it's been 5 years to the day since I lost and here it is, the anniversary, and I didn't even know. And like the body has a grief clock that's ticking away. And sometimes we try to not pay attention to it by distracting ourselves with work and play and other types of activities. But that clock is always ticking away in the background. And so it sometimes requires a thoughtful kind of process. So why am I so sad today? What set this up? What memory? What triggered that? And so it's paying attention to birthdays and anniversaries and losses from yesteryear, as well as the ones that are happening currently.
Thank you. We have lots of great questions. Another one, can you speak about systemic ageism on well-being, especially in light of Dr. Becca Levi's study on the impact of ageism and people living 7.5 years less when internalizing cultural aspects of ageism?
Well, I couldn't even, could you repeat that?
Yes.
Yeah.
Yeah.
A mouthful.
Could you speak about systemic ageism on well-being, and
Yeah.
especially in light of Dr. Becca, hopefully I'm saying this right, Levy's study on the impact of ageism and people living 7.5 years less when they internalize cultural aspects of ageism?
So this is a huge subject. Ageism, of course, is rampant in our culture. We are a youth-obsessed culture. And everywhere we look, we see older adults being marginalized and not honored and cherished in a way that other cultures may do. And we are acutely aware in geriatrics of how we don't have the resources or the full support of generations of Americans who have really focused on the youth. And often older adults are left out when there are movements forward, technological surges forward, when there are pandemics, as we've just experienced. The older adults are the ones who suffer most and are most highly at risk for being marginalized and not having access to the care and the supports they need. And there is, of course, a dreadful consequence. Not only do we lose our connection to our generations that preceded us, but we're not honoring and taking care of the cherished loved ones who brought us to this point in the first place. So there aren't enough resources to go around. And so what we end up doing is triaging. And so I am always surprised at the difficulty getting the supports that I need for my older adult patients. It's a constant struggle. I think it requires agencies like AARP that really focus on the crucial aspects of aging that we can bring to Congress, that we can make sure that our issues are always at the front of the line and at the top of the stack on the table of legislation. And that's often where we're not getting the support we need in terms of research dollars for the studies that should be done in order to understand the full consequences of loneliness and isolation, as I've just mentioned earlier, and many of the other diseases. So one good example of that is with Alzheimer's disease. There's a huge amount of research, huge amount of money allocated for Alzheimer's research, but it's all about the drugs. It's all about these drugs that you heard about, the one that was just approved recently, aducanumab, a medicine that's infused and costs $56,000 per month and absolutely clears amyloid plaques, but it doesn't have any kind of effect on cognition. And it's really not clear if it helps improve survival. So why are we funneling all of this energy and money into a medication that really has no meaningful effect, but not attending to those issues that we know has a very powerful effect? That is, we know just by addressing issues like loneliness, managing depression, looking at the long lists of medications that older adults take, looking at diet and how that impacts our health, et cetera, et cetera. I'll get off my soapbox, but those are modifiable risk factors oftentimes that will significantly reduce the risk of dementia or slow the course of dementia in a more meaningful and impactful way than chasing after the psychopharm cherry of the day. So I have a lot of strong feelings about this subject, but it's a culturally based problem that we're all, I think, engaged in fighting.
Thank you. Another question, what's included in a cognitive screening?
So for primary care doctors who have very little time, the average is like 7.5 minutes per encounter, we recommend just a mini cog. And that could be something as simple as, I have some concerns about your memory. I want to check it real quick. Is that okay with you? I want you to remember these 3 things. You list off 3 things, don't forget them. And while they're trying to remember, you distract them with what's today's date, where are we located? And oh, by the way, can you draw a picture of a clock? So that clock drawing test is one of the old classic tests of executive function. Do you have the capacity to organize your thinking in a way to draw the circle, put the numbers in the right place, put the hands in the clock in the right place? It's a quick and dirty screening test, which is highly effective for executive function. While they're struggling with the clock, you say when they're done, what were those 3 things? And if they get all 3, good. Their clock looks fine, good. See you next time. If there's a problem with that clock, or if they only remember, let's say 1 out of 3 things, then you might want to say, let's do a little bit more investigating. Let's do the MoCA. And I would encourage anyone to look up the MoCA, Montreal Cognitive Assessment. It's a great test. It's a 30-point scale. It tests all kinds of aspects of cognition. It's a screening test. And if there are problems with that MoCA, then we would, of course, want to look more closely. We're looking for reversible causes of memory loss. So obviously, the most common cause of dementia is Alzheimer's disease, but there are over 90, there are probably hundreds of different reasons for dementia or memory loss. Our job is to find out if there are any reversible ones, vitamin deficiencies, thyroid problems, a tumor, any number of infections, except medications can complicate cognition. So the screening test is really a way to guide us in our workup to see if there's anything reversible, and if not, what are we dealing with?
Another question, are tests such as MoCA, can they be used with non-English speakers?
Yeah, good point, thank you. So MoCA comes in many, many different languages. In the old days, you could just Google MoCA, put in the language you want, it pops up, you print it, and you use it. Now it's actually required for copyright purposes that you have a special training. There's a training program that, in my last job, we had a grant, and we paid for this training for all of our providers. And basically just shows you how to do the MoCA, standardized fashion. And there's a MoCA available for using over the telephone or in a virtual setting. And the MoCA screening, again, in any language, is quite sensitive to cognitive problems. And it takes into account those who have poor levels of education.
Thank you. Another person asked about, okay, so you talked about the causes and impact of anxiety that occurs late in life. Can you also speak to changes that occur late in life for people who've had lifelong anxiety? And as part of that, what are the challenges, possible solutions for people who've been taking anxiety medications for years?
Yeah, that's a huge problem. So most anxiety disorders start in late adolescence, young adulthood. That's the biggest peak. Then there's another peak in late life, oftentimes older adults who have suffered a new medical condition or have been given a new medical diagnosis or have suffered some terrible psychosocial loss, are at high risk for anxiety. And so if you've already got an anxiety disorder that you've been managing over the course of a lifetime, then you add to it a new diagnosis of fill in the blank, lung disease, heart disease, stroke, etc. It becomes unbearable. And so it could range from panic attacks to just a generalized sense of anxiety, restlessness, and it impairs our attention, focus, and our ability to even take care of the most simple tasks. It cuts across all adults, and so no one is spared from anxiety given the challenges of aging. And the hardest part is reaching out for help. So older adults with anxiety tend to try and manage on their own. And for those who are willing to go through a workup, it's the same deal. You're looking for reversible causes of anxiety. Again, things like thyroid conditions, any number of medical conditions, medications, etc. Or other substances that are contributing, such as caffeine or alcohol. And if there's no reversible cause, then how are we going to treat that anxiety? And again, anxiety, like depression, is highly responsive to the right kind of therapy and the right kind of medication. And so I, as a rule, avoid those benzodiazepines, those medicines that are used to treat anxiety because of the risks and the side effects. And we prefer instead to use antidepressant medications at low doses and with close monitoring. And for those who have intractable anxiety, it doesn't get better with antidepressants. Oftentimes we'll add on a second medication, which can be helpful with ruminations and obsessive thinking that may be fueling the anxiety underneath. So it's a very complicated subject, but I just want to leave everyone with the understanding that it requires workup, evaluation, and sometimes a number of different treatment strategies that take time.
Thank you. We have a couple more questions on grief. One person's asking about, given that the pandemic has prevented people from engaging in regular grief practices and rituals, how has that impacted complicated grief? And another person asking about spirituality and its religion. It's important for well-being.
Okay, thank you. Excellent. I'll take the second one first. So
Okay.
I have a whole set of slides on spirituality, which I didn't include because of a short time, but there have been studies showing that people who are highly spiritual and have a deep connection to their faith or engaged in regular and active prayer have a lower likelihood of suffering from anxiety and depression, and it may in fact help with cognitive disorders as well. And so there is an effect of having the comfort and support that your faith brings. And so when people tell me they have a history of being very highly engaged with the church or the temple or whatever their belief system may be, and they've lost that connection, I encourage them very strongly to get back into it, because there's no better community support, number one, but also from the inside, that demonstration of faith towards a higher power, which can really help lift us through difficult times. The first question you asked about not being able to grieve or access is a huge problem. So older adults have been sharing with me how difficult it's been for them not to be able to get out of their home. They can't get to the cemetery. They can't get to their loved ones who have survived a loss. And so that disconnection from those markers or those supports is devastating. So what do we do? I mean, it's really as simple as putting on a mask and saying, you know what, we're going to do this. And you go and pick up your loved one, you take them to the cemetery, or you take them out, or you help them re-engage in the age of COVID. And it's really a nuts and bolts grassroots effort to bring people back to those supports that they've lost touch with over time.
Another question, how can someone access a geriatric psychiatrist?
So here at Cambridge Health Alliance, we require that our patients have a primary care doctor within Cambridge Health Alliance, and they would help make a referral to myself or one of my colleagues. There are a few geriatric psychiatrists in private practice still in and around Boston. And I would say most of the major medical centers have geriatric psychiatrists as part of their faculty and staff. There is, as I mentioned at the beginning, a shortage. But that being said, you can usually get an appointment for an evaluation or consultation. And so what I've been doing more and more, instead of filling up my caseload and not being able to take on new patients, I work primarily by consultation. So the primary care doctor is the one in charge, and I'll see anyone they refer to me and make recommendations. I might see them once, twice, 3 times and make suggestions about therapy or medications or other types of treatment, and then kick it back to the primary care doc who will carry that forward. And that way I can keep seeing new patients. That being said, there's a large subset of patients that need ongoing care for their chronic conditions. And for those folks, we have a whole team of geriatric social workers, psychologists, with clinical nurse practitioners who are specialized in geriatrics, and we manage their care over time.
Thank you. We have a couple questions about sleep. One person asking about melatonin as a safe option, and does that help with REM-D sleep or REM/deep sleep? And another person asking if a person has to kind of wake up frequently to void at night and this interfering with sleep, what are some strategies?
Oh, excellent question. So yes, I'm a strong proponent of melatonin. Absolutely recommended for most of my patients who have sleep disorders. The problem with melatonin is it's often underdosed. So, if you're starting with 1 milligram, that's too low. You got to bump it up first to 3. That doesn't help. Try 5. That doesn't help. I would go up to 10. I have one patient who swears by 20. That's probably too much for most people. It's very safe. You really can't hurt yourself with melatonin. But I would say the dose range between 5 and 10 milligrams at bedtime would help with some of the restorative sleep problems that older adults tend to have. It can help with deep, slow wave sleep and dream sleep. And it's, of course, natural. Our body secretes melatonin naturally. And so it's the safest and most effective for some people. And when not, then it requires a closer look at other variables that may be at work. What was the other question? I forgot.
Somebody who, when people have to wake up frequently.
Of course,
Yeah.
how could I forget? Okay, so obviously the issue is one of the bladder, and all the doctors say the same thing. You got to stop drinking fluids after 6 p.m. But even when you stop drinking fluids in the early afternoon, there still is a problem having to get up to void. And so that's if there is an underlying infection or enlarged prostate or other issues that need to be addressed, of course, that's number one. So you have to see your doctor about that. There are a number of medications, the diuretics, of course, being primary, that will cause frequent urination. And until you address the dosing or the timing of that dosing, there's no way to avoid that side effect. But for most people, if you can get it down to 1 or 2 awakenings at night and you're able to fall back to sleep, that's not too bad. If you're waking up every hour, that's not acceptable because you're not able to get that deep sleep that you need to really function the next day.
And this is a great group. We've had so many great questions. Someone else asked, you mentioned older adults have a pretty low rate of depression compared to other age groups. Can you talk more about that?
Yeah, so it's not a low rate, but rather it doesn't increase. So a lot of, I teach a lot of the young residents in our training program here, and they all have these misconceptions. And this is really an ageism kind of misconception. That is, the older you get, the more likely you'll be depressed and suicidal. Well, yes, there is an increased risk for suicide for older adults, but in fact, young people attempt suicide far more often. The only problem is that older adults are more successful. When an older adult says, I'm done, this is it, I'm checking out, they tend to use more lethal means. And so if somebody's got a firearm and they're dead set on ending their life, there's often, we don't know about it and there's nothing we can do to stop them. And it's just heartbreaking. But that is one of the biggest risks of untreated or unrecognized older adult depression. That being said, young adults who are in their 20s and 30s are at high risk for depression, and often as well unrecognized and not treated effectively. But when it is recognized and treated effectively, those folks have a better course or a better likelihood of survival into their latter years. And so there are actually 2 different groups. There are the young people that get depressed and really suffer with this chronic illness for their entire life. And then there are those other older adults who have their first episode of depression late in life. And late life depression, as I mentioned, is more highly correlated with medical conditions, medication toxicity, other losses that we've already talked about. And those adults in particular need often specialty care because they don't often respond to medications in quite the same way as younger folks. Younger people tend to respond quite robustly and well to the antidepressants. Older adults, it depends on what's causing that depression. It depends on what other medicines they're on and what issues they're struggling with. And that's why it requires a specialty assessment.
Thank you. Somebody has a question about peer support or peer counseling, which actually we're hoping will be the topic of our next webinar.
Oh, wonderful.
Yeah.
I love it. All for it. Yes, peer counseling. There's nothing better. So peers who have been through it can speak to the matter from the heart, and they often will make a connection to people that clinicians who are overstressed and overburdened and don't have the time to spend really can't. So I am all for peer counselors and peer specialists being involved in care. And so we try to involve peers whenever we can. I know there are really great peer programs at the VA and other hospital systems. I strongly support and advocate for that work.
Wonderful. And I want to end with a couple comments from our attendees. One says, do get on your soapbox. It's so important to counter our drug-centered focus. And another says, we need to speak up, rise up, and start a tide of change. We are the largest age demographic.
Yes, yes, yes. I strongly support that. I'm really glad to hear those comments. Thank you. That's really great.
And thank you so much for coming and for a wonderful presentation.
Thank you, Cassie. I appreciate it.
For joining us, and have a great rest of your day.